We're hearing a lot now in cancer management that personalised medicine, targeted medicine, and thankfully we're hearing a lot about research that's led to development of new drugs to target specific receptors. Can you tell us about mutation testing? What does it mean? What does that mean for the patient? And how does that come into determining how you plan treatment for patients?
Well, so as Leora had mentioned, that all advanced stage patients will, at our facility, will get triggered reflex testing for a specific panel of mutations that are actionable mutations that can have a clinical impact on how we treat the patient. And that's very, very important. From the standpoint of the radiation oncologist, as systemic therapy improves and as patients live longer and longer, local therapy becomes more and more important. And so there's many patients who have stage 4 lung cancer with actionable mutations that are treated with TKIs that I will then see and treat for oligoprogression, a site, for example, that will grow, and so we can keep the patient on that TKI a little bit longer, the tyrosine kinase inhibitor. So it's most important for systemic therapy, but from the standpoint of a local modality like radiation, the better the systemic therapies, the more important local therapy becomes.
And you've talked, both of you, about these mutational testing for systemic disease, but should we not be offering this to all patients for all disease? Surely some of the treatments that are coming out apply these mutational markers. Is it not best to know that for everybody with lung cancer?
Right now, for patients with early stage disease, cure is generally achieved with surgery and chemotherapy. And the reality is that if a patient progresses, you shouldn't treat progression based on a CT scan. They need a new biopsy. You need that second biopsy if you're suspicious that the cancer is back to confirm the cancer is back, because as you know, things can mimic cancer, so we never treat off just a scan. So at the time they get that new biopsy, we're going to do the molecular testing at that time.
So do you ever have the situation where a patient may present with what appears to be good prognosis, localized disease, they have surgery, and then they come back to you with recurrence? Do you think that for those patients, if you had mutational data up front that may indicate this is more aggressive than previously thought, higher risk of recurrence, would that not give you a heads up earlier in the game to think about treatments for patients who may be at high risk of relapse before we see anything on scans?
Right now, the biggest issue with that, so that can happen, but some of those mutations are what we would call not actionable. So for example, if a patient with early stage disease has a KRAS mutation, we know that that's a poor prognostic indicator, but it doesn't really have, it's not an actionable mutation. There's no targeted therapy out there for KRAS positive lung cancer. And so having that information doesn't necessarily mean that we can help those patients with earlier stage disease increase their chance of cure.
And tell us a bit about the role now of these PD ligand medications for managing lung cancer. They're being used not just in lung cancer, but many other cancers. They're targeting the immune system. Are these medications, is this the way forward? Are these better tolerated than chemotherapy, or is it just that they're better at controlling the cancer in the first place?
Well, I think that there's a defined subset of advanced disease patients who can be treated with these and can benefit from these. The PD-1 and PD-L1 pathway is just, in my opinion, the tip of the iceberg in terms of what is on the horizon for immunotherapy. And the big picture concept is using, harnessing the body's immune system to help fight the cancer. But in terms of what these drugs actually do is they help the immune system recognize the tumor and help the patient's immune system fight the tumor.